Hello everyone. I am Joe the Science Bro, and this is the segment that we are starting to call Science Talk. So, as we normally do with this segment, I will introduce our special guest, and then we will have some short conversation about his origin in science, some of the research that he does, and lastly, we will open it up to many questions. But as always, if the questions are topical as we go through, please put them in the chat, and I will be more than happy to relay those questions on to our special guest. And please allow me and please join with me in welcoming our special guest today, Dr. Fred Goldstein. Dr. Goldstein, thank you so very much for joining us today here, and please welcome to the stream.
Thanks. I appreciate the opportunity to talk about science anywhere, anytime.
Great. So, Dr. Goldstein, if you could, I have been hyping up your time here on this channel as
pressure's on.
There you go. The pressure is on. Could you describe what pharmacology is for me? real quick, because that's how I've been kind of describing you to people. So,
Sure.
what is pharmacology?
I can do it in less than an hour.
Okay.
So, basically, it's the study of drugs
Mhm.
and specifically how drugs work. How does morphine relieve pain? What does it really do at the cell level? But it involves everything else about a drug. In other words, its uses for sure, its adverse reactions, serious, non-serious, its drug interactions, which is now a big issue. And so it basically encompasses everything that you think about a drug that is in the literature that we cover.
Okay. So, are you doing drug discovery work as a
No.
pharmacologist?
Not in the pure sense, drug discovery, I think from what you're asking is, are you making a new drug, a new
Yeah.
entity, a new molecule? No.
Okay.
But it is discovery in terms of what do these drugs do? A lot of that comes from the drug company, but actually a lot of it comes from nature. For example, morphine, which is the basis of all drugs used for major pain, comes from the opium poppy.
Right.
Aspirin and all the related products that are out there, like ibuprofen, et cetera, come from the willow bark. I mean, just to name a few. So drugs are discovered in the lab by synthetic organic process, and they're also extracted from plants.
Okay. I know that in some Asian countries, they're still using a very, I don't want to call it archaic method, but they're almost using a method where they're actually taking the roots, the shoots, the dried leaves, the bark, everything. They're grinding it up and they're actually boiling it almost as a tea. Is that a better way of delivering the compound, or are there pluses and minuses to it?
Well, I would just roll back a little bit and say, do they work?
Yeah, that's
Okay.
always a good question.
And if I can divert a little bit into that, there is a placebo effect.
Okay.
Okay, and a lot of the methods that are used, I'm sure, have some effect because we know that the roots and bark of some of those, again, the willow bark, gave us basically aspirin,
Yeah.
salicylic acid, which converted into aspirin. But until it's tried in a clinical test where there is placebo, because placebo can produce analgesia. Placebo can make somebody nauseous. When I look at drug studies and they test it against placebo, that can have some effects that are really generated by the brain. So you're asking me, do they work? Some do. And is it an effective method? Yes, if you can drink something orally and it's already dissolved. It doesn't have to be a capsule or
Right.
a powder that has to go into solution. If it's already dissolved, yeah, that can begin to work pretty quickly.
I know that especially when you're isolating it, it's in the way that it's kind of traditionally done in those kinds of teas. It's almost difficult to get the concentration almost exactly every single time. And I know that with the modern drug process, we're very specific in the concentrations that we use. But to roll a little differently now, could you describe for us why did you get into pharmacology as a whole? Could you spin us a small tale of your origin?
Yeah, basically, my dad, who died many, many years ago, was a pharmacist. So at that time, in those days, there was a pharmacy on almost every corner. It was a small store. They usually called the pharmacist doc, even though they were not a doctor. But there was a lot of compounding. A doctor would write a prescription which contained maybe 3 or 4 ingredients that have to be mixed, weighed out, balanced, and either in a liquid form or ground up in a mortar and pestle. So I was very interested in that. It was an all-encompassing thing. We knew the community. My father was very involved, like most pharmacists were. And when I was somewhere around 10, he taught me to say acetylsalicylic acid, which all my friends said, "What are you talking about?" I said, "That's aspirin, acetylsalicylic acid." And I also learned to make capsules. He had basically lactose, or like sugar pills, and took gelatin capsules which were empty, and then you had the powder, and you put one capsule into the powder and tamped it down until the capsule filled with powder, and then you took the other one and closed it. So I was fascinated with that stuff. And so I went into pharmacy as an undergrad, but in my third year, I had a course called pharmacology, and that really turned me on. This was, as I mentioned earlier, how do these drugs do that? What do they do? What are the side effects? All that stuff. And I said, I'm hooked.
Mm.
So that was my undergraduate degree. I went into grad school and got my PhD in neuropharmacology on synaptic transmission, how cells communicate with one another, and began a teaching career.
Lovely.
So
So, then how did you transition into doing research questions?
Well,
exactly.
yeah, when I said teaching career, I should have said teaching and research because
Okay.
I've always done both.
Okay.
I was at the University of the Sciences, which was primarily teaching, so big T and small r, but I always did research.
Mhm.
It was not a major grant obtaining institution because we were doing major teaching, which I have enjoyed to this day. I'm at the medical school now, finishing up my 30th year.
Mhm.
So I've always done research. Pain had a particular interest in me in terms of curing it. Well, I shouldn't say curing, but certainly relieving it.
Mhm.
And so I've had a number of publications in that area. And then there was an interest in THC, which for me started decades ago. When I say decades, I mean decades ago. And did some early animal studies showing THC had some pain relieving qualities.
Mhm.
And then coming up to the med school, there's an opportunity to do clinical research. So
Right.
I still teach, which I love, and I still do clinical research with THC, which I also love.
I have to thank you because I told you this before. My father was a teacher, and I've always had great respect for teachers. So if I may, thank you for your time as both a researcher but also as a teacher, because that is a very important part in my mind to both the nature of the world, because that's what keeps things going is the next generation, but also I think it's one of almost the most purest, if you'll allow me the word, vocations in the world.
Thank you, Joseph. And I in turn respect teachers as well. I mean, I tell people a story. You know, they say you may not remember who won the last Super Bowl, although unfortunately as a Philadelphia Eagles fan, I will remember who won. But you remember some of your teachers. And I had a teacher in third grade, Miss Epting, and we were studying fractions.
Mm.
And I was third grade, so I don't know, how old are you? I forget, maybe 9-ish, somewhere around there. And at that time in my neighborhood, we walked to school in the morning, walked back for lunch, walked back to the school, and then walked back afterwards. But on the way up, on one of my journeys, there was a crushed tobacco can of tobacco, and the brand was half and half.
Interesting.
And we were studying fractions. So I picked it up out of the street and dusted it off and brought it in. And she knew that I wasn't being a jerk. That,
Right.
you know, I didn't know.
You were curious.
I was curious, right. And she actually displayed that with all this other things that the kids brought in. And I felt validated, and it began to impress upon me, gee, this teacher really took me seriously. I wasn't, as I said, trying to be a show-off. So, yes, I've always enjoyed the fact. And the other thing I just mentioned quickly is somebody said, well, you've been doing it for so long, don't you get bored? No, because the audience in front of me, now future docs, have never heard what I have.
Right.
So for them, it's new stuff. So I'm never, ever bored. If I was bored, it would be time to leave.
Yeah. No, that I do understand. And again, you know, that's why I like to think of teaching as a vocation, because like you said, you felt validated simply because she recognized not only your curiosity, but your way of being topical on what you were learning.
Right.
And
she knew I was getting the message.
Mm-hmm. And that's one of the things that my father stressed to me is that being a teacher doesn't just mean rattling off the information.
Right.
You have to get the students to buy into what it is that you're actually teaching.
Right. And the other thing I'll add is that there are times when a student will come into my office, sit down, and go over some pharmacologic fact.
Mm-hmm.
And what really, really lights me up is I'll go over it, and the student will say, "Oh, now I get it."
Yep.
And I can tell you that's a joy for me, because they really do understand it. I'm not just, throwing out facts, but I'm really helping try to understand some things. And so as I said, I still get a joy from all levels of teaching.
Great. That's one of the things that I've always enjoyed. When I was doing my undergraduate, my graduate work, I had the opportunity to assist in teaching microbiology, and it was one of the highlights of my time there was being able to provide just that little bit of perspective that I had as a bioinformatician geneticist into bacterial genomics and the way that students can learn from it. I do have actually a question for you in regards to the placebo effect.
Okay.
So one of our audience members is asking, in some cases such as relief or pain or nausea, couldn't the placebo effect be almost as valuable by itself if it produces the intended effect?
Yes.
There you go.
I mean, yeah, that's why I said that the placebo effect is real. And in terms of, I never treat any of my patients with a placebo who have pain.
Right.
Just won't do that. They may get an active drug that I'm working on, and they may get a placebo on top of it to see if there's a combination, but I will never do that. But the placebo generates effects within the brain. For me, the first episode, I was not in grad school, but again, it was my father's pharmacy, and there was a patient who the doctor called my dad and said, "You have a placebo," because this patient wanted a sleeping pill. And the doctor felt that she didn't really need it. So my father did have some placebo medication that I had made actually as a pharmacy student. And delivered it to her, charged her a small amount. You can't say, well, hey, it's a placebo, it's free. So we charged her the smallest amount that we could. And she called back the next week for a refill. The doctor only ordered 7. So my father called the doctor. He said, yeah, go with it. So I said, I would like to take it back to her house because I had this really inquisitive mind. And I did bring it back, and I said, how did it work? And she said, oh, I just took one of these, and I just went right to sleep. And I knew exactly what was in there. It was the placebo. So there is a placebo effect that's generated from the brain, and it's powerful. But we do need to assess it because, let's say a drug produces an effect of 60%.
Yeah.
Okay. Placebo might produce an effect of 20%. So if the drug is producing a 60% effect and the placebo is 20, then the real drug effect is 40%.
Right.
So, and then it can produce side effects. I mean, that's absolutely,
Right.
you don't have to take it from me. You can look at any FDA label that's online of a drug, and they will show you the patients in placebo who get nauseous and who get dizzy, and it's pretty powerful. So we take it, but there's also something called nocebo, which is something that produces negative effects.
Okay.
Really just only negative effects.
So what could you elaborate on the nocebo effect?
Well, I mean, it just produces things that you wouldn't normally expect from a placebo.
Interesting. So getting on the topic of side effects, one of the things that we had discussed in prior episodes was the almost laundry list these days of side effects that we're starting to see in modern drugs. Is this more because we're looking for those side effects, or is it a rushed nature of the design process, or is it just a better way of us diagnosing?
Well, okay, so you're talking about the side effects that come out with the FDA report. Right. And they do a clinical trial. Right. Okay. So the clinical trial is designed to identify all those things.
Right.
And there's a percentage. So as my friends tell me who now see all the stuff on TV, my God, who would ever want to take a drug? Well, that's always the way it's been. Yeah. But you don't get everything. So how does a doctor make a decision? Well, there's a percent. Some things occur at a high percent. And if 60% of patients get dizzy, that's probably not going to progress into clinical trials unless it's a type of drug that is for, let's say, a type of cancer that's really, really deadly. Patients might be willing to experience that. Yeah. So that's the balance that I'm kind of getting into. Okay. There isn't any drug today that has 0 side effects. Right. So what does a doctor do? Well, if a drug causes liver damage, even if it's only 2%, they need to tell the patient. Right. Generally, we don't get into it unless it's 5% or more. Okay. But the patients these days are given information from the pharmacy, and it's all there. But the doctor will go over the most likely things on a percentage basis, or if it's a small percent, if it's seriously toxic, like kidney disease or liver disease. So
One of the things that I saw when I was looking up certain details about you,
Okay.
don't take it the wrong way.
No.
I saw that you were looking into, I believe it was C-section pain therapeutics.
Right.
And that was a combination of, I believe it was drug and osteopathic therapy.
Okay, that was the C-section was seeing a pharmacologic event. It wasn't what I was doing was similar. It was a hysterectomy.
Okay.
The C-section one that I mentioned was one of the most amazing things I saw in pharmacology because I was doing a study on post C-section pain and I was in to observe one. I have 4 children. None were born by C-section, but it was amazing to me because I was in the OR. I was working with the anesthesiologist. The C-section was going on. I was standing there looking at both sides of the curtain. There was a curtain so the woman would not understandably want to see her open. But I did. And on one side, the doctor was opening her up and they were getting the kid out and she had this wide incision. And on the other side of the curtain, she was talking to her husband about what they want to have for lunch. And it was one of the most amazing pharmacologic things I've ever seen.
Interesting.
The study I did with LMT was using morphine before the incision and osteopathic manipulative therapy after surgery. And what I found was the combination of giving an extra dose of morphine 10 minutes before incision plus osteopathic manipulation for 3 times for 2 days afterwards did reduce the amount of morphine that a patient needed for their pain. And they were on what we called a PCA, a patient-controlled analgesia pump, where within limits they could press how much they need. I mean, it was controlled. They couldn't overdose.
Yeah.
But on their own control, those 2 combinations, morphine before, osteopathic manipulation after, did reduce the amount of morphine that patients use to relieve their post-hysterectomy pain.
Could you briefly, because I know that you're not an OMT specialist, but could you briefly describe what OMT is in regards to this particular study?
Yes, again, I'm not a DO, but with osteopathic manipulation, there are certain things that they can do to relieve certain muscle that are tight, which would increase the flow of fluid through lymph to the area to promote healing.
Okay.
And there is a lot of research on one-to-one type patients where patients will come in and they will be treated and they will feel fine. There's less data on large groups being treated. And one of the things that I've done is to have OMT done in a specific sequence.
Gotcha.
In other words, it was the mantra is you treat what you find, which I respect, because they will feel for different changes in the body.
Right.
But is there a specific sequence, like in science, where this is 1, this is 2, this is 3, this is 4, which is not done routinely, but in order to have good scientific evidence, you need to have it done that way.
Yeah.
So that's how this study was done in cooperation with Dr. Alex Nicholas, who was the DO who formulated the study, and that's what we did. The OMT was in a specific sequence. I also, in that study, did a sham.
Okay.
Which meant, why did I do that? Well, touching, we all know, is very powerful.
Yeah.
Whether you're touching your child or it's a spouse or loved one, whatever, touching is a very powerful thing. So I wanted to have it touching so that people could say, well, of course it worked. You touched them. So there were some patients who were naive to osteopathic manipulation, who didn't know, who were touched. The hands were placed on them, but they weren't manipulated. But they were absolutely touched skin to skin. So that I could say if it worked, yes, everybody was touched, but only those who had the manipulation did receive benefit.
Okay. Whenever I talk about morphine, because it's a little topical in this current conversation, I always want to get the feeling from someone who has done research into the topic. What do you feel about the irony of heroin being a treatment for opioid and morphine addiction when it was originally produced, and then people would end up getting addicted to the heroin instead of the morphine?
Well, first of all, I will acknowledge that when heroin was produced, I want to acknowledge the Bayer company.
Yes.
Okay. They did not produce a drug to cause addiction.
Right.
Okay. No company wants that to happen.
Mm-hmm.
It happens, but no company wants it. Why did they produce heroin? Well, they had aspirin and they had morphine, but they figured, is there a way to make this more effective? And what they did was they took morphine and added some hydroxyl groups, a few groups. So it's actually acetyl group without getting into chemistry. It's diacetylmorphine. They added 2 acetyl groups, and they made the morphine molecule more lipophilic, or more lipid soluble, or more fat soluble.
Gotcha.
What does that mean? It means they can get into the brain more quickly because there is a covering around the brain that's lipid in nature.
Right.
So they wanted to have a more effective analgesic. They did it.
Yeah.
Okay. But as characteristic of any drug in any class, the ones that are going to be abused in any class are more lipophilic because they get into the brain quicker and they develop a bigger bang.
Gotcha.
Okay. Morphine gets in, it takes a little bit longer. Heroin, it's in, and that generates it. Now, cocaine, okay. Cocaine base, free basing, that can get into the brain faster. Methamphetamine gets into the brain faster than amphetamine. So in any group of drugs that are going to be abused, the ones that are going to be abused have a higher lipid solubility.
Gotcha.
So we can't blame the drug companies for that part. Now, without getting in too much in the opioid epidemic, but I will a bit, if that's okay.
No, that's perfectly fine.
The drug companies didn't do the best job in monitoring what happened. Fentanyl is now an issue. Fentanyl is not going away. Fentanyl is a very valuable drug. As I tell my medical students, it's not the drug. So the drug companies who produced this, one in particular, Purdue, was pushing the doctors to write this saying it wasn't causing any addiction, and it was a lie. But a doctor gets comments from a drug company, you would think that why would a drug company lie? Well, they did because they were pushing profits.
Right.
So in that case, the drug companies, some of them did a very bad thing. The same thing for the wholesale companies who had records of opioid sales that were going to these small communities. Somebody should have looked and said, wait a minute, why are all these opioid pills, these Percocets, going to this small company in Kentucky, small county in Kentucky? Nobody looked at that. They didn't care. So I will blame them to some degree. But the bottom line is, it's not the drug.
Right.
And as I tell my medical students, future docs, who are going to be treating pain, I want them to understand that. And what do I use as an example? The alcohol. I will tell them, I ask them about what % of people that drink alcohol do you think become alcoholic? It's about 10%. Why isn't it 100? If alcohol, ethanol, ETOH, if ethanol didn't, if ethanol made you an alcoholic, everybody who drank alcohol from one drink of champagne on New Year's to a couple drinks a day, everybody would be an alcoholic. So my point is, it's not the chemical. And I feel bad because, there are people on the ad say, well, I had a knee problem, went to my doctor, got Percocet, now I'm an addict. Okay, it wasn't your doctor's fault.
Yeah.
So I just want to make that clear.
I do understand what you're getting at.
You can't blame the drug. And the thing about addiction is it works.
Yeah.
I mean, if somebody's really stressed out, alcohol can relieve them. Or Valium type drugs can relieve them. Or if they're feeling really depressed, cocaine can relieve that. Or amphetamine can relieve it. So we have to understand that they're self-treating.
Right.
And treatment involves getting them in to the point where there can be therapy to find out what is the cause of their problem and how can people help them get through this without the use of drugs. So I've been lecturing a long time in this, Joseph, and it's drug abuse has been with us for decades.
Yeah.
I wish it weren't. Can I just add one more point on that point?
Absolutely.
Part of it is genetic, but there is a large significant involving parenting. And I feel bad for parents who have a child, and nobody wants their kid to turn out that way. But I will tell you, the data that's published show that parents who are involved with their kids, who love them, show them love, who respect them, who have limits. Like, no, Harvey, you can't stay out till 12 o'clock at night. Why? Because you're 8 years old.
Right.
You're going to come in earlier and go to sleep. Those kids are less likely to become involved with drugs. And we don't say, really, I'm using drug addicts. It's those with substance use disorder. It's a shame. It's a very tough field. I wrote a letter to the Philadelphia Inquirer several months ago. A sports writer was talking about Phillies fans being addicted to the game. That really, how should I say it professionally, urinated me off. So I wrote a letter to the editor, and saying that this person should not use that word in that context. Addiction is not fun. It's not fair, and it can be deadly. And that was, and that was published.
Yeah.
And then over the weekend in the Inquirer, another sports writer did the same thing. So I haven't sent my letter in yet. So we want to help these folks as much as possible, but there are some genetic issues. Even under the best circumstances, parents do the proper thing, and sometimes there's a genetic fault.
Right. So so the way that those drugs, especially the psychedelics and different mind-altering substances, pain medications, the way that a lot of my professors put it in context for us was that the concentration that gets you high is the maximal concentration without poisoning yourself. Is that about correct?
Okay. I'll play the question there. Define poisoning. Do you mean toxic?
Yes, toxic.
Well, I mean, there's two aspects to that.
Yeah.
When you're using drugs like that, they do produce toxicity, not necessarily death. Okay. A lot of it, by the way, is just a little side vent, but not major. There are harm reduction places. We have one in Philadelphia. Right. Some of the side effects, the bad effects, are from sharing needles, hepatitis.
Yep.
Tuberculosis. So some centers, no questions asked, will just give them. They can't shoot up there, but at least in Philadelphia we don't have those. Yeah. But they'll give them the new needles to reduce the spread of that. So there is some toxicity not associated with the drug.
Right.
Yes, they try to get high, but the problem is that the brain is protective.
Yeah.
And it's just like, again, I ask my medical students, talk about tolerance.
Yeah.
How many drink coffee? They'll raise their hand. A couple cups a day, raise their hand. I said, well, get up Saturday morning and have 0 coffee. And I hear the groans.
Yep.
What happened? The brain, when you're taking a stimulant and turns the brain up, inside, the brain turns itself down. Because the brain's job is to keep you normal. So you drink more coffee, and the brain turns itself more down. The reverse is true with depressants. The person who has a problem with alcohol needs 3 or 4 drinks to get the brain sufficiently reduced. But the brain is turning itself up. So now the brain is acting at a higher level to counter the drop in alcohol. Is that explanation going okay so far?
That makes sense to me.
And so when somebody gets up in the morning who has an alcohol problem and hasn't had any alcohol, the brain is still wired, and that's why their hands start to tremor. So the same thing with the person who has a substance abuse problem. They keep pushing it. They're going to get to a point where they can't steal enough to get enough money or prostitute themselves, male or female or whatever, to maintain their habit.
Right.
Then they crash.
Yeah. So, would you say that the ramping up or the ramping down that you were describing, is that related more to the homeostatic process that the brain has gotten used to because of the drug in question, whether it be alcohol or caffeine or whatever stimulant or depressant is in use?
Right, and that's why when we bring somebody into the hospital, we're going to gradually withdraw them. We will give them some. You mean you actually get? Yeah, we actually do. We'll give them an opioid, and I won't get into the details, but we'll give them that to stabilize them.
Right.
And then once we know they're stable, meaning that they won't have a seizure, they won't die, then every day we reduce it by about 10% per day. So they will experience some withdrawal reactions, but the safety factor is if they have a seizure, sometimes they're given medication as the withdrawal process continues to prevent a seizure.
Right.
but it's not over usually a week to 10 days.
Gotcha. So I guess the ideal situation here would be if you got a patient in and they were willing to allow themselves to, I guess, kick the habit under supervision, you would slowly wean them off the drug over a period of time.
Yes.
Okay. Is that patient always going to have that urge afterwards?
Well, it's a great question, and the answer is possibly. Depends on what got started. I mean, if you have somebody whose life, and I remember meeting one person with a drug problem, and he told me his words, I get up in the morning and I put on my gray clothes and I eat my gray food and I go outside and it's gray. But he said, Doc, when I do that heroin, sunshine. So what is the cause of the problem? Okay, if there's a psychological problem, and a number of individuals who have a problem do have some psychological deep ones, possibly even psychosis. Okay, so they need to be treated. If it's a matter of somebody not growing up with proper feeling of themselves, that they like what they are. They're not overly, in terms of egocentric, but at least, okay, I'm not the best, but I'm pretty good at this, I'm pretty good. They have some confidence, and they may have hit a rough spot. Then you can maybe get them through that spot, and they don't have to go back into drugs again. But if you don't really find out the nature of the problem, even though you withdraw them, based on your question, if there's nothing done to find the etiology or the cause, they'll probably revert back as soon as. And actually, for some, it's better now because now they're out of the hospital. And now instead of 10 bags of heroin, they only need one. And they need less money to steal.
Correct. It's interesting that you describe the change in color and perception. One of our audience members described it very correctly. There was a video game that came out recently. When I say recently, I mean several years ago. That was entitled "We Happy Few," and it takes place in an alternate version of England where the entire populace is taking massive amounts of mind-altering substances.
Oh, really?
Yes, because they're
interesting.
They I won't get into. I can describe for you the story later, but basically they did something so horrible at the end of the Second World War that the entire country did not want to remember it at all.
I see.
So they're on a constant medication so that they will not remember.
I see. Interesting.
Yeah, it's a very interesting idea. And it's interesting that you describe it in such a way because that's actually how the perception of the game is. When you're not medicated, everything is gray, dull, it's very drab. But as soon as the character that you're playing is on a significant enough concentration of the drug, everything is bright and colorful. Even the street that you're walking on is bright lights.
So now you got me interested, Joseph. So what drugs were they taking?
Well, that's the thing. I never played it, so I don't know. But I do have one question that I think is very, very interesting for us. How hard is it to balance restricting sales to addicts for opioids and other pain meds as opposed to, say, people with chronic pain that need to stay dosed?
Well, there are some difficulties, okay? And one of them is because too many opioids were sent out from the hospital. For example, after surgery, and I'm not knocking the physicians. I teach in a medical school, so I'm proud to be associated with future docs. But there was a time when patients would get more than they need.
Right.
And it wasn't anybody being malevolent. They just wanted to provide the patient with stuff in case they had some pain and they wouldn't have to keep calling the doc.
Right.
But they really didn't pay that close attention to it because we didn't have a problem. And all of a sudden, it seems like the excesses were being used improperly. So what has happened now is there's been a funneling so that for a particular surgery, when you leave the hospital today, you're going to get a much more limited amount.
Yes.
That we know from experience will cover. If you have a certain surgery, X may give you 5 days of pain. So you have 5 days with the option to renew, but to call the doctor so they can closely monitor it. What has shifted in the other end is people now having pain because some docs are afraid of creating the addicted person, and that is a problem. Now, to that end, when I did some clinical research at Walter Reed Army Medical Center in the 80s, I was working with the doctors. Again, I'm not a physician, I'm a medical scientist, but I was working closely with the docs, and they would, after they knew me, go in and see this patient. I had chart privileges. What do you think? And it was wonderful. But one of my patients was in so much pain when I walked in, she tried to commit suicide in front of me. At that time, the oxygen mask had a metal flange around it. And she took it off and she tried to slit her wrist. I was right in her room. So I coined the term suicidogen. Like carcinogen, which causes cancer, suicidogen, in my view, is anything that causes somebody to think about or commit suicide. So if you look up, not suicidogenic, but if you look up suicidogen, if you Google it, you'll get my paper. And now we have those cases where we have more people suffering than need be because some docs are just not aware. And if they, as I tell my medical students, you should know how to handle pain to treat it. And when it's gone, the whole realm. If you don't know how and you don't have the proper training and you need more, don't treat patients because you're not going to do it right.
Right. So this, like the Alzheimer's that we discussed with Dr. Balin, it seems as though the pain management issue and the abuse of it is a multifactorial issue where it is both psychological, it's physical, it's also a perception issue, and it's also the pain as well. How difficult is it? I mean, because every single patient is different, and every single patient has different tolerances. Depending on their background, they might even require more or less concentration to make it physically relevant. How do we handle these unknowns?
Another good question. I get that from my medical students. How do we know, Dr. Goldstein? How do we know? Well, here's how you know. The patient comes in, and if the first thing, unless it's needed, you may prescribe, and you don't need a prescription for it, like an aspirin type product.
Right.
Or acetaminophen, which is available as Tylenol.
Yeah.
And if the patient says, yeah, but doc, Percocet really works for me. Okay, the first signal you start to have is the patient is now starting telling the doctor what he or she wants. When you go to the doctor, you're there to present yourself for treatment.
Right.
And if you trust in your physician, if you don't, you shouldn't be there in the first place. All right, let's try this. So that's one of the things that begins to tell. Also, they'll have the history of the patient. Now, if you have a problem with a person who's been in a multi-vehicle accident, but he also has had a known problem, active problem with alcohol abuse. So that's a person that may have a problem with opioids.
Right.
So I throw the question out, so what do? Do you treat them? I give them some time to think about it, try to get some answers back. The answer is, of course you do.
Yeah.
Of course you do. You treat them, but you keep them on a very short leash. And if you know this as a physician, you say, listen, I know that you've had a problem, Harvey, with alcohol, so I'm going to prescribe Percocet for you, which I think will be useful, but I'm going to give you a 3-day supply.
Yeah.
And then let's see how that works, and then you can call me back. So it takes more work on the part of the doc.
Right.
Not a lot of doctors want to do that. I can tell you that for a fact. So there are pain management docs who are primed to handle it. So there are things to do. You look at the history, this person's been married, 5 times. I'm not saying they're a bad person.
Right.
You're looking at character. Do they have a
Right.
stable background? If a guy's 50 years old and he's had 10 different jobs, that's something. Again, I'm being very clear.
Right.
It does not automatically mean, but you start to get a profile of, and then, well, do we have other people who have good profiles? Yes, we have doctors.
Right.
And scientists and clergy who have problems with alcohol and drugs.
Right.
So there's no automatic profession that you can escape into that it won't happen. It can happen to anybody in any profession.
Would you, and this is just a pure opinion question, would you say that this is almost a disorder or a syndrome, if you will, that can affect anybody?
Well, it has the potential. But here's the deal. Kids go to college.
Yeah.
Okay. I have 4 wonderful children. They all went to college. Okay. When kids go to college, they experiment on stuff. right?
I
Well,
didn't.
I
was
would say
boring.
I would say the majority, will in fact experiment.
Right.
Okay, and as a parent, you don't always hear that until they graduated. But I have a pretty good connection with my children, so we talk about stuff. But so there is a lot of experimentation, but they don't go on. And again, what are the factors? I can tell you that if there's not a genetic issue, and I want to move away from that because I feel, some parents are unfairly tagged. But I can tell you that you produce a child, and I don't want to sound like I'm a manufacturer, but I mean, I love my kids. I was very involved with them, not because I had to. I'll be with them and doing and coaching their different teams. But kids who feel secure and self-confident can handle the rough spots.
Yeah.
And there are rough spots in college. That's why you need to go away to college and learn that stuff. So when you develop the ability to handle stuff, it's just like in PhD land.
Yeah.
We have projects that haven't been done before, which is what I like about a scientist. What I am doing, nobody's done before.
Right.
There may be some variations, but in the PhD land, you're not reading a book.
Yeah.
You're given experiments, and is this going to work? Well, maybe it's not. Okay.
That's true.
And then you have to back up and have enough confidence to say, okay, that failed. I got to go this way.
Right.
Because if you're really doing an extensive PhD project, it's going to be complicated.
Right.
So anything in life can be. All I'm saying is, based on your question, if you have a child who has known unconditional, and I mean unconditioned love, that, John, you broke the vase. I'm upset that you broke the vase. I love you,
Right.
my child, but why did you didn't listen to me? I told you to be careful running in the whatever you say.
Right.
I just saw a very impressive video on trauma a couple weeks ago, and it was a woman in a prison, and she was in the prison yard, and it was sunny, and about 50 prisoners were in a circle around her. And she said, okay, these were all individuals who were in jail, but they also had drug abuse problems. And she said, all of you who have never been hit, all of you who have been hit, severely as a kid, step forward. Almost everybody in the circle stepped forward. Then the things like, how many of you, all of you have not felt love and affection from parent, and they all kept moving. So what she was exposing is that a lot of the drug problems do occur from childhood.
Yeah.
Of course, we have the parents who think they're doing great by, hey, come on, Johnny, let's have a couple of beers. Well, he's only 12. Yeah, but he's going to drink anyway, so what the heck? So if one or both parents
Right.
use drugs inappropriately or alcohol, the kids are more likely. So there are multiple factors, but it goes back to the person. Now, if you have a normal individual who's like that, but all of a sudden you have a resident in medical school or in a hospital who loses a promotion or maybe screws up, and accidentally a patient dies because of that. That takes a lot
Yeah.
to overcome. Person may need to go on a leave. That sometimes can move him into it. I've had a physician who had such problems speak to my medical students. Good student,
Yeah.
good student in undergrad, good student in medical school, good resident, everything, but kind of was overly productive to hide some insecurities
Gotcha.
that he didn't get from his parents. And then something hit the fan, and he went into a addiction problem.
No, I understand what you're saying, and I mean, we have I don't know if you know her, Dr. Jess Kandorsky is going to be joining us on the show in a couple of weeks, and she's in the behavioral unit. I have a feeling that we're going to discuss something like this a little bit more with her, but one of the things that always struck me in school was that it never seemed that it was just a chemical dependence, that there was always something extra to these syndromes of addiction.
Yeah, there is. In the most part, there is. There's a triggering factor. And again, some people hide it by overproduction.
Right.
Or, you always hear, I mean, even hesitating to use this example, but I guess I will, that somebody is, well, he's always been pleasant, it's a great neighborhood trash, and you found out that, he hacked women to death in his basement.
Dahmer.
Okay, I mean,
I think the one interview of his one neighbor was, he was such a nice boy.
Oh, there you go. Right.
Yeah, he was such a nice boy.
Or somebody who's smiling all the time. I remember when I started out teaching, there was a professor who was always smiling, always happy. But it turned out he really was being treated for depression.
Yeah.
Hey, I'm not saying don't be happy.
No.
But I mean,
I myself,
people cover up certain things, and one of them is somebody who doesn't know how to, delegate.
Yeah.
I've seen this in some people who work in clubs or committees or whatever. No, I'll do it. Yeah, but we have a lot of committee members. Yeah, but I'll do it. And again, I know I've said this several times. Each factor that I'm saying isn't the factor.
Yeah.
But you've asked me about factors, plural, and there's different things.
Yeah.
So it is a matrix. But again, the core comes back to the person.
Yeah.
Again, I know I've said it many, many times. I don't have Alzheimer's yet. There is a genetic aspect, but a lot of it is behavioral.
Yeah, and I want to stress, just for the sake of not just relevancy, but also for keeping a good conscience for myself, that we're not saying that anyone who has addiction or has addictive tendencies is a bad person by nature.
Well, let me just jump in on that point, if
Please,
I can, Joseph.
absolutely.
That we try not to use that word, even in terms of, well, there's a diabetic,
Yeah.
there's an epileptic. We don't say that. We're trying to be softer. This is a person with diabetes.
Correct.
This is a person with epilepsy.
Yes.
This is a person who has a substance use, and even they're getting away from disorder. I have a little problem with that, but it's the person first.
Yes.
And then the tagline after that.
No, you're absolutely right. One of the things that I like to, because I work with a couple of students as well, it's almost, I feel, a personal responsibility, because I am a recipient of the healthcare industry, for me to give them my perspective as someone who is a care receiver, and say, there is a necessity for knowing how your bedside manner can affect your patient one way or the other.
Absolutely.
And one thing that I stress,
and we teach that.
Yeah.
We have our standardized patients. Where students are taught, to come in and don't stand up there and look down and say, "Hi, Mrs. Jones, how you doing?" Sit down.
Yep. Sit down.
Eye contact. Hi, Mrs. Jones. How are you feeling today? Just be calm and just be relaxed, and just so it's a softer approach.
Yep. Exactly. Well, here's a bit of perspective from one of our audience members. He thinks that most people have addictions these days. He thinks that an addiction-less person is actually a non-existent these days, that we're addicted to different things, whether it be social media or movies or TV. Like you said, the Phillies was an addiction. Do we need to change our almost our vocabulary as to what an addiction is? Do we need to find a new word for certain things?
Yes.
Yeah.
Okay, because addiction is what it means in the medical field. It's a serious problem. When you are an addict, you are not worried about your job. You're not worried about your spouse. The wife says, well, if you don't stop, okay, just don't shut the door too loud.
Right.
Okay, addiction is a terrible process.
Yeah.
It's a compulsive disorder. Okay, and what are you addicted to? Now, I'm talking about addiction, because I'm with respect to this question.
Yes.
We can have a deep interest. I have a deep interest in World War II. I used to play as kids. We were World War II Army guys, but I just followed a lot. I've been to Normandy beaches twice. And I read books on it. Doesn't occupy my life. When we talk about addiction in the medical field, this is a serious problem that the person is now basically non-functional in society.
Right.
Okay, that's the true meaning of it. Now, you can have a strong interest, a strong desire, an inclination to do a lot, but we have people who are addicted to the internet, who are addicted to shopping, who are addicted to sex, in addition to drugs. We have people addicted to tanning. We have people addicted to surgery. How can that happen? Well, unfortunately, you have some individuals who are surgeons who, if it's borderline because there's tissue committees, well, you operate on normal tissue? No, but if it's, enough, maybe most surgeons wouldn't, but this person, so that is true. So that if we're talking about addiction in my world, it is, again, to repeat, a serious compulsive disorder that you are not a normal person in society. I'm trying to answer the question.
No, absolutely.
But we all have strong interest in sports, in this and what. Yeah, I love sports. I think it's a great thing to watch. I really enjoy it. If the Phillies or the Eagles, lose a Super Bowl, what happens? Well, sad, but we don't commit suicide over it.
So, one of the things that I hear tossed around as a vocabulary word, my father was very big on vocab. I'm sorry.
No, go for it.
One of the words that I constantly hear is the difference between dependency and addiction. So, is dependency a better characterization of what we kind of colloquially deem as a addict to a drug?
Well,
is it more that they're
really,
dependent?
Not really, because what dependency is, the cancer patients that I have treated, not any right at the moment, are dependent on opioids.
Right.
Their life would be terrible without opioids.
Yeah.
They are dependent on opioids. How do they function? They function. I mean, one patient I had at Walter Reed was home vacuuming at home with a really high dose of morphine the day she died. So dependency, and the other dependency is I told the students, I was speaking to them last week, I drove by and there saw a bunch of cars in this store, all these people who were really interested, they had to get their drug, and what was it? Well, it was a Starbucks. Okay. It's caffeine. It's a drug.
Yep.
Nicotine, without getting on my soapbox, cigarettes should be banned, period.
Agreed.
They have no therapeutic use, and they're only toxic. What keeps a person dependent is the nicotine level. Anybody old enough to remember when they had all the manufacturers testify in court, or at the Senate hearing, not court, but there were court conditions, court battles won against them, that in fact they manipulated the cigarette levels to deliver nicotine. So they, in fact, are dependent on nicotine.
Yeah.
They, some people, well, it's been reduced a lot.
Yes.
Okay, we don't allow it in the med school. We haven't for years. I tell kids, well, not kids, young medical students, I remember as a kid going to movies with my parents, and the smoke was thick in the movie theater. In fact, my eyes are tearing up as I'm telling you this now. You get on a plane, I mean, it was everywhere.
Yep.
So nicotine is a dependency. Caffeine is a dependency. And so are opioids for certain patients. So I think that's how I clearly see, and again in my world, a differentiation of addiction and dependency. But if you have a strong interest or a strong following, or Joe is really interested in photography or something like that, to us, and I know in the lay press, it means a different thing. I understand that.
And that because I talk with Dr. Balin a lot about the need for different terminology and different vocabulary for when we're assessing someone who has dementia, because being demented has its own negative connotation to it that then affects that assessment process for someone who might not be fully cognitively impaired. And this is why I stress a need for such a we need benign terminology for what we're actually doing, so that one, we're not misconstruing our message, two, the patient doesn't become afraid, and three, they understand exactly what it is. It is a clinical situation that we are trying to treat with both a therapeutic, but also with empathy.
There are there's horrible stories, but one was relatively recent where a man killed himself and his wife because they couldn't get the opioids they needed.
Yeah.
The pharmacy was holding back until I'm not getting into the details, but it happened.
Yeah.
And it's just a horrible thing. So they were dependent. I mean, she was dependent.
Yeah.
And it was a real issue. So there has been some, there are treatments. For example, methadone started many years ago, decades ago. And the question is, well, you're giving them a drug. Okay, yes, you're giving them a drug. The question is, what do you want to accomplish? If you want to accomplish somebody who's drug-free at the end, they shouldn't get methadone. They should go into therapy, psychoanalytical, well, I shouldn't say psychoanalytical, but certainly group therapy, cognitive, and brief therapy, if you want them drug-free. But if you want to take this person and make them stable, a member of society, to live with their family, to not steal, to not commit crimes, to hold a job, to, in other words, be a normal citizen, methadone's fine.
Yeah.
Methadone's fine. And now we're into buprenorphine, which is another drug. And if I could just add a comment about my THC studies, that I treat patients with neuropathic pain. And some friends saying, even some students, well, aren't they looking to get high? No. They've had nerve pain, neuropathic pain for a long time. And I can tell you, I've been very successful in using THC to do that. It's a wonderful drug. It does not, repeat, does not cause somebody who starts with THC to want to shoot heroin the next day.
Yeah.
Even the federal government, on the National Institute of Drug Abuse website, has said, and I use this in my lectures, most people who use marijuana do not go on to hard drugs. Now, you may have heard, well, you know what, 100% of heroin addicts started on milk. People have said that.
Wow.
Okay. I'm telling you that that's not a factor, because it's the same thing with alcohol and everything else. So marijuana is a wonderful drug. There's less chance. I would rather have somebody have a problem with that than opioids, because we know the death rate with opioids is over 100,000 now in the United States per year. And you know how many people die from a marijuana overdose? I'll put you on the spot, Joseph.
I do not know.
0. Why is that? Good question. Glad you asked.
Yeah.
I'll tell you the answer. One man show here. No, you're doing fine, Joseph.
Thank you.
It doesn't affect the respiratory center. Opioids knock out breathing. That's how they die. Marijuana does not. So we have no case of somebody dying from an overdose. Now, I'm starting to see reports of kids who parents are not careful with their gummies and stuff, who have come into the OR, who one case had a seizure, one case had a cardiac issue. But they're getting large amounts and their systems aren't fully formed yet.
Yeah.
But at the adult level, that doesn't happen. Now, I'm not saying that you're a safe driver, you're not a safe driver. That there have been accidents where somebody's been high and their psychomotor reflex to hit the brake is slowed. It doesn't have to be slowed by a lot to have an accident. So there are secondary causes. But as a drug that's effective, that is non-lethal, but does have effects, for example, I would not recommend anybody under 25 to use it, because that can affect brain behavior. We've seen that. And women who smoke, there's evidence during pregnancy, there's evidence that that has an impact on their newborn. Those data are just starting to come in. So I'm not saying it's exclusively safe, but in terms of a drug to use, for example, in my area for pain, I think it's wonderful.
We're getting to that point where we're reaching the 1 hour mark, and I know that you had said that you wanted to evaluate if you wanted to keep going.
If there's some questions, I
do actually have a question, and I have a follow up to this one. You mentioned working at an Army hospital. What's your take on controlled use of drugs that aren't medically necessary but are intended to supplement someone's performance? For example, that came to his mind. Military's giving amphetamines to soldiers to stay alert longer, but it could also apply to athletes using steroids.
Okay, so there's two parts to it.
Yes.
Okay. I don't believe athletes should be given any drugs, period.
Agreed.
Okay. And it was very clear with Mark McGuire and Barry Bonds. It was clear. I mean, their heads even changed a bit. They had pictures of it.
Wasn't Griffey Jr. also?
Ken Griffey?
Yeah.
You might be right. You might be right. So, in my opinion, and they're not, I don't think they're listed in the record books, so steroids can do that. Nobody, in any field, even swimming, the difference, my older sons were swimmers, a tenth of a second is between first and third place sometimes.
Right.
It's
Exactly.
that close. So from an athletic standpoint, no, it should be pure. Now,
Mhm.
at an Army standpoint, okay, that depends.
Yeah.
Under normal conditions, no. But, I mean, God forbid if they're at the fight of their life, the Battle of the Bulge, for example, going into my World War II history, I know all
Yeah.
about that. I'm not sure what they did. It was never mentioned. But I would certainly favor giving them amphetamines. They were against an overwhelming force. Patton had not arrived yet.
Yeah.
It was cold, and they had to stay alive. So
Correct.
under extreme conditions, I would. Now, I do know that there was a story of some pilots in Europe who were on what they call go drugs,
Yeah.
which were the amphetamines.
Mhm.
Why do I know that? There was an article, sad tragedy. They decided instead of flying over a bridge, they were going to fly under a bridge. I don't know what country it was, but there were some wires hanging down underneath. They were never meant to have planes fly there. And
Yeah.
they hit a wire, and I think there were some people. I don't know if the plane crashed. I can't remember, but I do know that they were on what they called go drugs. And of course, the Germans used them. They developed that
Right.
during World War II. So, under normal circumstances for Army activities, no, because eventually your mind gets tapped out. And when they wear off, you're going to fall into a zombie like you can't be aroused, and then you are dead
Yeah.
in a sense if the Army comes after you.
And that actually is.
So I hope that clarifies a little bit.
Yes. That is actually one of the statements that one of our viewers actually said. He was saying that the Germans used the amphetamines to keep soldiers going and awake in battlefield, but often when the drugs stopped working, they'd end up dying in the action because
Yeah.
we didn't know how long it would work for. Every single person's different. And two, in the heat of battle, you can't take that next bump to keep yourself going.
And also, what is prevalent with what's going on in Ukraine is, as a
Yeah.
top general said, quantity is quality.
Yeah.
So unfortunately, that's what the Russians are doing with their soldiers. I won't get into the political end, but I mean
Yeah.
in terms of battle stuff. So if you outnumber them, and of course, eventually we did with the Sherman tanks,
Yeah.
which were not as heavy as the German tanks, but the problem was we had to ship them across the Atlantic Ocean.
Mm-hmm.
So we couldn't make tanks as heavy, but
Yeah.
we had plenty of Sherman tanks.
Exactly.
And that's how that helped us win the war.
Mm-hmm. No, I agree.
Sorry, my World War II stuff's showing, but
No, it's
hey,
okay.
it works,
I enjoy reading a lot of the novels and memoirs and journals of certain leaders, and it's always very interesting to read Rommel's perspective and Patton's perspective and actually see how very alike they were in the way that they enjoyed prosecuting war. I shouldn't say enjoyed because Rommel didn't enjoy war. He actually thought that it was just a necessary exercise in life.
Right. Patton did.
Patton did.
Yeah.
He thought it was a game.
He didn't want the war to end, or he wanted to go in. He wanted to go to Russia. He wanted to go to Russia.
So one last characterization on that topic before, because I do want to get into some of the THC if that's possible.
All right, sure.
I know that because I have a couple of friends that are in the Marine Corps. I know that the Marine Corps tends to give a lot of analgesics out, and well, I shouldn't say analgesics. It's NSAIDs out to people in very high concentrations and very high dosages, to the point where a couple of my friends have started calling it grunt candy, and it's basically Motrin. It's ibuprofen in very high concentrations. Does that lead to a dependency?
No, because it's really not a psychological effect.
Mhm.
I mean, it really shouldn't. Not from what we've been talking about
Right.
during this
Because
session.
I know it's an anti-inflammatory drug.
Well, that's overused. And again, I tell my
Yeah.
medical students, as a pain guy,
Mhm.
the most stupid ads on TV, and I'm not going to name the product because when I'm in class, I'm being recorded as I am now. But, oh, my knee hurts. Well, I take drug X, and guess what? I can play tennis all day. No,
Right.
that's stupid.
Yeah.
Okay, pain is a signal
Yeah.
that something is not going well.
Mm-hmm.
And all that these drugs do is mask the pain, mask the protection. What you should do is you should relax it, stay off it. And this is where you get into the tennis addict who can't stay off it
Right.
and continues to play. But when you take these drugs, unless you have something like arthritis, which it can reduce the inflammation.
Right.
But if it's a thing, a muscle cramp or something, you need to rest it and not take it. So I am sorry to hear that about the Marines, but
Yeah. Well, I think it's become a more of a controlled issue now because it was made popular in a TV show as well. But I did have some friends who have told me that actually it is something that still occurs, but it's a little more.
Well, I would wonder about, I hate to jump in, but I would wonder about the rate of breakdown.
Yeah.
Are more of their friends breaking down sooner for longer?
Yep.
Do they? I don't know if they're studying that, but
I don't.
I didn't mean to jump in. But I
No,
just thought
no.
that,
It's a good question. It's a good thing to ask. So I did want to get into THC studies because you had mentioned it. There are. This is a very hot button topic currently in the modern medical and modern recreational world. Could you elucidate some of the process that you've had to go through in order to even test using THC?
Okay. I'll just summarize. THC is the molecule, delta-9 tetrahydrocannabinol. Okay. I can say acetylsalicylic acid. I can also say delicatessen. A lot of big words. Anyway, Marinol is a drug approved by the FDA. So delta-9 THC, the active ingredient in marijuana, is an FDA-approved drug.
Interesting.
It's approved. I used it on campus for my neuropathic pain study here. And I have that on campus because it's an approved drug. Again, I'm not a doc, so I have my colleague, Dr. Catherine Galuzzi, work with me, and I'm the leader of the study, and she works with me, but she'll write the prescription, and we get that in. Now, the other THC, we have a large grant from Organic Remedies. And they have provided this medical school with millions of dollars to do research. They have THC, but I can't have it on campus. It's the same molecule. Why? Because they get their THC from growing marijuana in their grow fields. Growing marijuana, it's a Schedule I substance, which is illegal. So if marijuana is illegal in the United States government, anything from that is illegal. Gotcha. So where am I doing my studies? In a suburban area outside of Philadelphia, in a dispensary. It's legal in Pennsylvania. It's still illegal in the federal government. Right. There'd be thousands of people in jail it'd be hundreds of thousands across the country. So that's, I have to run the studies at different sites. If I had the Organic Remedies THC, which is the same THC in capsule form, on campus, and the federal government decided, well, you've now got a Schedule I substance, we lose our Medicare money, our Medicaid money, and our federal student loan money, and the school shuts down tomorrow. Oof. So I have studies. I have a research coordinator out in a suburban area, and we recruit patients. We just actually had, after setting it up for a year, our first patient last week who's doing very well. Great. I have a THC CBD 1-to-1 capsule that the company has made for me. And we're starting out at a low dose and working her way up. I use the 0 to 10 pain scale. We don't have a painometer where you can put on it. You're putting 7 points. Right. We don't have that yet. Maybe someday, but 0 to 10 works. So my 7, maybe your 5, Joseph. My 5, maybe your 7, but it's consistent. Yeah. And if we can get a drop in 2 of those points, that's clinically significant. This 0 to 10 has been used for a long time. Right. So she just started with a relatively low dose. Her average was about 4.9. Now it's down to about 2.9. So she's had already a 2 drop in
That's
pain.
fantastic.
It is fantastic, and I feel wonderful about it. So does she, and she sleeps better. So this is but it's a combination. So those are the differences. And that's kind of my studies just beginning to take off in that realm. So, because you can't talk about THC without talking about the other major chemical that's involved in marijuana, which is CBD. Yeah, so I said it was a THC CBD. Could you? What's the difference? Obviously, because they're different chemicals, but what's the major difference between the two of them? The major is the psychoactive, which is why CBD, you can go into a store in anywhere in Pennsylvania and buy CBD. Yeah, you don't need a license. Right. The major difference is the psychoactive process, where THC will in fact do that. Yeah. So, but CBD has some anti-inflammatory properties which seem to be better, because I noted in this patient she was on a non-steroidal type
Okay.
drug. Again, I don't want to mention the name. It was an aspirin type drug.
Yeah.
And she found she had to take less of it after a week.
Mm-hmm.
I didn't expect that. That's called serendipity, because I didn't know she had osteoarthritis because she didn't tell us. She just had nerve pain.
It's very
And I'm not her
interesting.
doctor, so
Yeah.
what brings her into my study? Neuropathic pain.
Right.
But she has found that it might be helping her arthritis, which fits with CBD. So again, the major difference is from a psychoactive, THC will produce it, CBD doesn't. Now, you can have a product with up to 0.3% THC in the product and sell
Yeah.
it. But to illustrate the problem, there's now Delta 8. That's not regulated. Everybody's, the government's freaking out on that because Delta 8 is not regulated.
Yeah.
So again, it goes back to you can't control the products.
Yeah.
You never will. If you never will. Fentanyl. It's not going away. It's a major drug used in the OR. We use the drug in cancer pain. There's a fentanyl patch,
Yeah.
and it's not going to go away.
Mm.
So those are the differences, which drives me crazy. But I was hoping that the federal government would change it, but nobody wants to touch it. No president wants to touch it, and therefore we kind of languish.
No, yeah, I do understand what you're getting at. I mean, it's, again, as I said when I first got onto it, it's a very divisive topic. Everyone has very strong feelings about it, and it almost seems, because whenever I look up in Google Scholar any information regarding THC and CBD or any kind of marijuana-based therapy, I either get something that is extremely anecdotal in terms of a clinical study, or I'm getting almost conflicting information from different people in regards to that. Is this a situation where almost we don't have enough information regarding the product or regarding the chemical, and we need to do more work on it in order to get something out of this in terms of a therapeutic? Or is this something that it works for some people and doesn't for others?
That's where I come in.
Well,
Here I am. Send me your money. How I got a study for you. No, there's a lot of science that hasn't been done.
Mm-hmm.
And they have these ads on TV. And again, I'm not going to mention names. Somebody says, "Oh, I want my memory, and I take this drug."
Yeah.
I'm Einstein. Okay.
Yeah.
Maybe it's a placebo effect. So there are not a lot of scientific studies, which is what I'm not the only one.
Mm-hmm.
There are studies using THC in the United States, but you have to use the government's THC,
Right.
which is grown at, one of them is the Mississippi School of Pharmacy.
Mm-hmm.
They grow marijuana for the government. But again, we have a large grant from Organic Remedies, so we're using their THC. It's the same molecule. So a lot of the studies are just that, and particularly what's a problem is, well, it's smoking.
Yeah.
I mean, I read a study where they said people who were smoking marijuana needed
Mm-hmm.
more pain meds after surgery
Yeah.
than those who did not use.
Hmm.
That suggests to me tolerance. How much did they use? We don't know.
Yeah.
The study was, did you smoke marijuana? Yeah. How many joints a day? And what about the dosing?
But even
I'm using specific dosages.
Yeah, but even
my study involves oral.
Yeah.
Or they're capsules. I know the specific dosage, so it's a very specific study.
But even then, if they're saying how many joints did you smoke, that doesn't suggest how much.
No,
of
but I'm trying to answer your question.
Yeah, no, exactly.
Because of those things, does somebody feel good? Yeah, but we talked way at the beginning of this about placebo effects.
Right.
Placebo, you expect to have pleasure. Nocebo, they expect to feel bad.
Right.
It's the opposite effect.
Yeah.
But that's why the studies are necessary,
Mm.
and that's where I come in.
No, absolutely. I know that again, as I always say with these science talks, this is your personal time, and I greatly appreciate you taking some of the time here.
Sure.
I want to give our audience a few moments so that we can wrap up.
Okay.
I want to give them a few moments to kind of type in any questions that they have left.
Okay.
For this time, is there any questions that you might have for me regarding anything that you might want to ask me?
Sure. It's like I say to a server who comes over, do you have any questions? Yeah, what is truth?
Oh boy.
No, I'm fine. I think your questions were fine. I
Thank you.
tried not to get too much into the weeds with some of these, but I thought the questions were very good.
Thank
I mean,
you.
they were right on the topics of what we deal with, and I didn't want to divert into the non-scientific aspect of responding to sports writers, but I think we're talking about a societal issue. So I'm happy to discuss it. I appreciate the opportunity. But
No,
if there's
and
another question too, I can take that if your call.
absolutely, and that's one of the reasons why I'm very glad that this has been very well received amongst my audience, is because I want to make sure that proper communication occurs. When I had Dr. Bravo Nueva on, one of the things that he said was that we as a scientific community failed the general populace in terms of the COVID response. We didn't provide a good enough message. We didn't provide good enough education for people. We didn't teach them what was going on, and that what they were seeing was science in action.
Well, I disagree.
That's one of the beauties of science, is that we're able to disagree and then have discourse.
I think the government did an admirable job, and I think that I don't want to get political, but it was a political person with wrong things
Yes.
that screwed this up.
No, I agree.
No,
that,
I'm just going to say that's a science thing. We're going to inject what? I mean,
yeah,
and these are fraudulent. All these individuals.
that I do agree with.
And that was the problem. Thank God that he wasn't the president again,
Yes.
or we would be talking about millions and millions of deaths.
Mm-hmm.
So I disagree with the person you just quoted, Dr. Bravo Nuevo, I believe.
Mm-hmm.
I don't want to mispronounce his name.
Yeah.
But I think, they did a really good job in trying to isolate it, identify it. It didn't take that long.
I think what he was more saying was in our ability to effectively communicate to someone who is a layman. Because a lot of what was discussed and brought out to many people was in heavy scientific jargon. And that did a large disservice to many people. I jokingly said to my mother and my wife, do I have to get the whiteboard to explain this? So, because I had a whiteboard at home, and I was almost drawing pictures almost every single night to explain heavy concepts. But I think that's where we as a scientific community have almost, and I've been saying this a lot with this show, is that we almost hide behind jargon sometimes. And we almost gatekeep from the general populace. You are doing an amazing job by effectively communicating about THC and its ability to assist in pain management.
Well, thanks, but I think that there may have been some issues that weren't. In fact, I think that part of, to support some of it, Governor Cuomo, who left in disgrace, but he did have his weekly show, and he was more
Right.
of a lay person. I agree with that to some degree, but no, I don't think the fault was the government at all. I just think that it was a very complex issue. It wasn't like the measles.
True.
They didn't even know what they had.
True.
And for Fauci to put all that stuff together, I really do think that maybe some jargon a little bit, but but it's better to say, well, yeah, if you inject some Lysol or whatever.
Ugh,
I mean,
no.
Are you kidding me? How far do you think that set us back? And there are people who still believe that this thing was a government plot. Are you kidding me?
Yeah.
A government plot? I mean, you may not like the United States government. And I would say to a lot of people who, if you don't, okay, you can leave. If you
Even
go back to your country of origin, whether it's Germany or whatever. But they're not perfect. But I really think they did the best job they could under the circumstance.
No, and that's completely understandable. And again, as you said with me, to a certain extent, yes, I completely agree with you in that regard. I did want to mention this very quickly because this is a question that I have. Because I recently saw a video on it, and I'm very sorry because I said that this was going to be it, but pneumatic injection in terms of vaccines. Mm-hmm. Can you describe why we don't do pneumatic injection all the time?
No, I'm not really sure. I mean, obviously you know how it works.
Right.
You put it on and it blows it through the
Yes.
skin. So the molecules have to get through.
Mm-hmm.
If they don't, if you don't succeed, then they're going to stay on the outside, and they're not going to work. So I don't know the exact answer to your question. Certainly by injection, we know it's in.
Yeah. So I guess in that regard, it almost answers itself because it could potentially be a penetrance issue.
Well, I'm just on. I don't
Yeah,
know.
no.
I do not know the answer. I do know it's the other thing. And thinking about it is that the process is simpler because I get my flu shots at the pharmacy.
Mm-hmm.
You know, and of
Yeah.
course that changed. I mentioned my dad was a pharmacist, but
Mhm.
these days you can walk in and you can have a pharmacist give you an injection, which is wonderful. That never was
Yeah.
even close to being considered back in the day. So the needle is a simple process for a injection, a machine to kind of pump it through. You've got to have the equipment. I'm sure it's got to be at this proper pressure. I'm sure there's a lot of aspects to it. So just think about it for the first time. That may be the answer, but I would have to believe ultimately it's the efficacy, and maybe backup is the cost.
Thank you. I appreciate your candor, and I appreciate
my
your
thoughts.
conjecture. You know, I want to echo a couple sentiments from our audience. It's been an absolute pleasure having you here,
Okay.
and I really do hope that you will be able to join us again.
Sure.
Especially because there's going to be more information probably that you'll be able to share with us in the future, and I hope that there is.
A year down the road, I hope to have a lot of patients to talk about. Sure.
I truly hope so too. Oh, what is this? We have one last question.
Okay.
Have you heard of the board game Campaign for North Africa? And would you ever dare to play it? It supposedly takes actual days to play, but is highly historically accurate.
No, but I would play because we won.
Well, that is.
I mean, sure. Why not? I mean, there's a famous scene in the movie Patton, and the reason I like that movie is because Bradley was in a lot of the scenes, and a lot of that information was taken from people who were with Patton.
Yep.
And there was the scene where there was one of the major battles in North Africa, the first one, that Patton was up against Rommel
Yeah.
and won, and was told later that day that Rommel wasn't there. Patton was saying, I beat him, and I hate to tell you. So Patton was really upset, but the aide said, and there may be some, I don't know the wording, but he said, but Rommel had a plan, General Patton. You beat Rommel's plan, therefore you beat Rommel.
Yep.
Oh, okay, good.
Yeah.
Sure. Was that a video game?
It's a board game, apparently.
Oh, I'll have to get it. Sounds great.
But if I can take just a few moments, I want to thank you very much for your time. As I said before, this is your personal time, and I really do
No, I
greatly
the
appreciate
opportunity.
that. Again, I truly wish you all the luck for your study, and I hope that it generates data, whether that data be exactly what you want or it be the truth of the situation. I really do hope that you get the data that you need.
Well, I just want to say, I mean, 7 of 8 patients on my THC alone study have been successful.
Excellent.
So this is not a large 1,000-patient, double-blind, placebo-controlled. It's not. It's a proof of concept. But so I've had some pretty good success. But
Excellent.
Thank you again for the opportunity and great questions from the audience.
Thank you. Thank you so much. And again, we would love to have you back at any time. And I do hope that you have some more information to share with us.
I think I will.
Thank you. Thank you so very much. Well, let me take us home, and then we'll be able to be done. I want to thank you all for joining me tonight. Obviously, I will be placing this on YouTube probably tomorrow. If you enjoyed the stream, I hope that you will give us a follow. It does help us continue to go. And I hope that you will also like, comment, and subscribe on this and in the channel, because it does help us get through the YouTube algorithm. It does help us get out there to everyone else. Also, if you could, it would be very helpful if you could also share these videos as well. I want to thank you all again once more, and I have to thank Dr. Goldstein once again for joining us.
Should I
And
play this as we leave?
no,
Okay.
unfortunately.
Okay.
Thank you all so very much. So long, and thanks for all the
Bye-bye.
fish. Thank you.